All right, folks, I think we'll go ahead and get started. If someone on the call could just verify that they have audio and slides up. Anyone can just unmute and or give a thumbs up or something, but
Sounds great.
it's wonderful. Thank you, Rob. Appreciate that. So we're at the bottom of the hour, and I think we'll go ahead and we'll get started. Um, This was a lecture that we had done last year in the spring, and there seemed to be some desire to have this earlier in the season. So we're going to go ahead and do this earlier. And this is going to be, I think, important for the fellows because we get a lot of information about, we'll have things about communication, about family conferences, and the importance of the communication and that we engage with our patients and families. I wanted to get a little bit more basic though and talk about actually the language that we use and the words that we use. And this just comes from years of observation that words do matter, that it can make a huge difference in our patients' lives in terms of specifically how we approach specific topics and the words that we use in helping our patients and families navigate these things. So we're going to identify some language, and everything that I have on here in terms of some of the language actually came from patient charts. So this is real stuff. This is not hypothetical. I want to look at the negativistic terms that we use in medicine when caring for patients with terminal illness and make some suggestions for perhaps some more appropriate and useful verbiage that we can use as physicians in helping our patients and families. And then we'll close this with one of my pet peeves, and that is the militaristic metaphors that have become absolutely embedded and ingrained in our medical profession and is used liberally by healthcare systems and hospitals to market their services. And so we'll talk a little bit about that. But for starters, I have no disclosures relevant to this presentation. So we all learned as kids that sticks and stones may may break my bones, but words will never hurt me. Nothing could be further from the truth. Words hurt because words don't just describe things, but we do things with our words. We make requests, we give warnings, we give invitations, we make promises. We apologize, we make predictions. All of these are important aspects of how we use the words. And our medical care system is not always that delicate, empathetic, or honest about how we engage these. And finally, we as hospice and palliative medicine practitioners are often called upon to care for people who have been damaged by words. The words that other practitioners have used and the way that they have used them have taken patients and families down a misguided path, have filled their brain with ideas or misconceptions about their disease or the treatment possibilities or their prognosis. And we often are called in to undo those. And so recognizing how these words can hurt others and how we can then use our words to help to rectify these situations is, I think, very, very important. I'd like to start out with a common phrase used in medical care. We've heard this all the time. We've seen this all the time. I've seen it in charts. I've heard it from docs when they proclaim, "I'm sorry, there's nothing more that we can do." Now, I would first say that, the clinicians that are uttering this typically are well-meaning and they're compassionate. I just think they're misguided. This is one of the most demeaning, dehumanizing, and demoralizing phrases that we can use with our patients because it's typically spoken at a very critical juncture in the patient's disease trajectory. They're getting worse. Things are getting a little out of control. They're desperate for some sort of answer, for some sort of direction. And what they are told and what they hear is, "Oh, nothing else we can do, sorry." And this results in these feelings of abandonment and betrayal. And so I think we need to be particularly careful about ourselves not using this and to recognize when patients have been told this, that they may be stinging as a result of that being done. I remember years ago in my more militant days, I would tell medical students if I ever heard that they are uttering this, I'll cut their tongues out. I felt that strongly about that phrase. And it is a consequence of the medical system that is centers on a fix-it mentality. You know, that's what we're trained in medical school, how to fix things, right? And so if you fix it, if you can't fix it, then I'm sorry, I can't do anything else for you. It's a default and the expectation of practitioners, hospital staff, patients, and families that disease-directed care will always continue. And I think this is, again, a misconception that we, that we have to overcome, that the care is not always disease-directed. It can be directed in a much different way. But this also then fosters that same ethic that if it can't be fixed, then nothing else can be done. We must also, we must always be mindful that we treat patients, not diseases. We're not treating the lung cancer in room 426. We're treating Sam, who happens to have lung cancer. So we are always treating patients and managing disease. I realize that might for some just seem like a little semantic flip, but I think philosophically and emotionally, it's really, really important that we never forget the fact that we're treating patients and we're not treating diseases. Because once we objectify that patient into a disease, it changes the perspective of how they will be approached, how they will be viewed, and how they will be treated. There's this implication that medical interventions is inherently good, and thus not providing interventions must somehow be bad. And this becomes an issue if we choose to adopt a pattern of watchful waiting, which might be the best and the most appropriate course. It also, if we think that always intervening is inherently good, we're going to be motivated to do more, when doing more in terms of intervention is not the right thing to do. And historically, this has been ingrained as not intervening as someone was dying was equated to neglect. Why would you not, throw everything, including the kitchen sink, in an attempt to, I'm putting in air quotes, keep someone alive? But as we all know in our profession, it's not all about length of life, it's about quality of life. And so we need to, and I'm going to talk a little bit about the importance of honesty as we move forward. And it's interesting how this negativistic creep has come into our lexicon. So when we think about much of the language around decisions in these circumstances are always framed in the negative: withholding, withdrawing, deprescribing. These are all words that are suggesting that something is being taken away. And anytime a change is anticipated, which suggests that something is being taken away, there must be reassurance indicating that care is continuing, if not escalating, in other domains. We have to emphasize the things that we are going to do and not just focus on what we're not going to do, what we're stopping, what we're taking away. And we know that particularly in the hospice realm, people come in and some of the first things we do are, we change their medications, we take away a lot of the drugs that they no longer need. We let them know that it's probably not necessary that they go see their cardiologist anymore. They're not going to get those follow-up weekly CBCs, all these things that we're taking away. And it can leave a patient and family feeling a little bit disconcerted that, wait a minute, what are we going to be doing then if we're taking all this stuff away? So we want to make sure that we recognize that a lot of this language is negativistic, and we need to be focusing on things that we are going to do for the patient and for the family and supporting them at this very, very critical juncture of their illness. Not saying there's nothing more we can do. It may very well be that we can't cure that anymore, but there's still so much that we can do. And so I think we need to help patients get over that when they have been told that by their subspecialist. So an example of some alternative language that we can use. The plan that we hoped would address your underlying disease is no longer as effective as we had hoped. So we're going to shift our focus and we're going to change the plan of care. So we want to make that type of an ethic our focus in terms of how we are going to relate to the patient and family when we, in fact, are changing the plan of care. We want to continue to explore alternative options for symptom management if current strategies are not effective. One of my stock idioms that I would use with my patients, I would say that I have a very, very deep bag of tricks, and no one has taken me to the bottom of that bag yet, and you will not be the first. They need to be reassured that we will leave no stone unturned to try to accommodate the symptom burden that accompanies their illness or their treatment course, and that first and foremost, we must always promise non-abandonment. We're not going to leave them. We have their best interests at heart. We understand what's going on and how this is impacting them, and we're going to work tirelessly to try to remedy that. So when we focus on that particular process, then what we'll see is that this issue that they were thinking nothing more can be done is way in the background now, because we continue to intervene, we continue to address the issues that are of concern to them, even if we cannot cure a disease. So related to this is, and another way that our words can sometimes get in the way and trip over things is in prognostication. If, especially the fellows, you may not have necessarily experienced this yet, but for those of us that have been in the field for a while, we can all absolutely affirm that one of the most common questions that we get is, well, doc, how much longer do you think I have, or my wife has, or my dad has? Prognostication is an important part of what we do. It's not an exact science. We'll have a lecture on that later in the year, and hopefully, which we can kind of clarify some of the science behind it and get better at it. But these types of phrases that I have heard docs utter, no one knows, only God knows. I don't have a crystal ball. But here's the deal. We do, in fact, have prognostic tools, and we can provide perspective. And sometimes the patients are not looking for a day on the calendar that they can check, but they're looking for some sort of overall guidance on how they can live their life. And if they have a general sense as to how their disease might progress, we're often pretty good about telling people that we got something we can't cure, we can't fix. Well, then what does that mean? But we can provide that perspective. It may be days to weeks, it might be weeks to months, months to years, or it might be a number of years. We can use language such as this, and this is, again, terminology that I've used with patients. It is true that most people with this disease ultimately die from it or complications of it. But the fact is that we may not know exactly how long you're going to live, but we would expect that many months to maybe even a couple of years would be well within the realm of possibility for you. But it's not going to be 20 years. It's not going to be 15 or 10. Just the nature of the biology of this disease suggests that it's going to result in death before then. But our focus will be on how to help you live fully and abundantly, no matter how much time you've got left. If it runs a little quicker than we expected and you've lived fully, that's a wonderful thing because you've lived well. If you happen to live longer, then that's great also. I had a circumstance once a few years ago in which I'm talking with a woman and her husband and one of her children about the fact that her cancer has progressed despite all available anti-cancer treatments, and that this is going to be a terminal process for her that's probably measured in some number of months. Of course, there's tears and there's things like that, and so then we allow the emotion to express itself, and then we start talking about, well, what has been important to you, and what has been sacred to you. What are the things that you want to be able to accomplish with limited time left? And she said, well, one of the things that's always been really important to me is Thanksgiving dinner. That was when all the family intentionally gathered, and there were wonderful, wonderful, meaningful times of family gathering. And this was May. And so I said, well, how about if you just simply plan your Thanksgiving dinner over the Memorial weekend? Family can gather and you can do that then. And you could just see this little spark that she hadn't thought about that. And that was a really kind of a fun thing for her to think about doing. And so just there in the room, she and her daughter began, who's going to call who's going to bring what, and they would do this. And then she got this almost a panic-stricken look on her face. And she looked at me and says, well, what happens if I live to November? And I said, you can do it all over again. So we just need to make sure that we're framing the prognostication in such a way that people do have that opportunity. I remember I was speaking with a group of docs many years ago. And this is not a group of HPM docs. This is a group of hospital-based physicians. And I just asked them a simple question. I said, would you live your life differently today if you really knew that this was going to be your last fall on Earth, or your last Thanksgiving on Earth, or your last holiday, whatever it is? And you could see people nodding their heads. Well, sure, I would live differently. And one smart ass in the back said, well, I sure wouldn't be sitting in your lecture right now. And I said, exactly. We need to make sure that we're being honest enough with our patients that when we understand that, they understand it. And we don't try to hide that from them so they can live their life richly and fully and meaningfully. Our opportunity in helping them understand prognostication in that general way will be of great value to them. We can avoid specific numbers. We don't have to give them, and I had a friend of mine last fall who called me, and he just had visited his oncologist. His numbers were kittywampus, and he knew that they had no further treatments. As the doctor said, I have 2 weeks to live. So I drove, he lived in the South. I drove down south and visited him on day 13 and told him I can be very confident you're not going to die on day 14. So we had a little chuckle about that and talked about what was important and how we're going to continue to manage the symptoms and what he would be doing in the weeks subsequent to that. So let's avoid the specific numbers, but do be honest about how we're prognosticating. Now, I want to use some themes and examples. We're going to talk about current state, future state, and implied states. And these are patients, and these are things that are direct from hospital charts. And I think it's important to understand, because you will see these, and I think that we need to sort of think about how can we remedy when we see that the patients have been impacted by language. And it really also reflects sometimes the medical team's reluctance to address this up front. I'm going to say a word of that in just a minute. But so current state is to describe and identify the current process in the state of dying. I would say that these couple of statements are pretty clear. The patient is dying. The patient is at end of life. I'm okay with those. But here's some of the things that we see. High mortality risk. Situation is potentially a terminal event. Grave situation, critical condition. Patient is at end stage. Now, I don't know what end stage is versus end stage, but that was in a chart. Patient is extremely unwell. Now, again, these are all patients who the clinical situations that they're dying. And these are what the physician said about that. Doing poorly, irreversible state. You can see how unhelpful this type of language is. So I would just, going back here, these are the types of language we want to use. You will see these sorts of things, and don't get yourself caught into a track of using these kinds of descriptors. So we think about the future state. This is a patient that is in a terminal course and dying is going to be likely in the future. And these are the things that I mentioned earlier. Prognosis is hours to days, maybe hours. Likely has hours to live. Those are very specific, and you get a very clear picture of what to expect, and that really helps the patient and the family. I remember I had a patient once that came into our inpatient hospice unit had been well. He was a mid-50s gentleman that had a seizure out of the blue, and he came in to the hospital and, of course, went through the neuro workup and scanned, and he had this absolutely horrific looking astrocytoma with tentacles all the way through his brain. How it didn't affect him symptomatically sooner was a mystery. The extent of it was such there was clearly no operative options, and they really this is many years ago sort of ruled out any sort of intervention. And he was going downhill so quickly. At the time he hit our door, he was actively dying. And I asked his wife, who was appropriately tearful. I mean, 2 weeks ago he was fine, and now he's being told he's going to die from this disease. And I said, what did the team share with you about how long they expected him to live? And she looked at me and she said, well, they said that most people who have diagnosed with this cancer and don't get treatment die within 6 to 9 months. So that was her expectation based on what the physicians had told her. And I've got this guy in front of me who is actively dying. And so I said, well, what does your heart tell you? And she looked at me and she said, I can't see how he could live much longer like this. And I told her, I said, your instinct serves you well. Let's talk about what today is going to look like. And we were able to walk through what the actively dying process is. But again, a circumstance in which someone was cloaking their reluctance to be honest with the patient in some population statistics. And we have to keep in mind that many prognostication algorithms are based on population data. And that may have no relevance to the person at hand. I was just, I think many of you on the call know that I underwent a lung transplant a few years ago. I was 6.45 years, right there, years ago. And at the time that I had the transplant, I was told that the average life expectancy in that program was 6.8 years. So you can imagine that I won't know precisely the day on the calendar, 6.8 years from the time of my transplant. That's coming up right at the end of the year, right after the first of the year. Now, of course, we know that those are just averages, those are population statistics. And I just was meeting actually last week with the transplant doc, and I said, so what do you think now? And she smiled and she said, well, you're much more likely to make it to 10 years than you were at the time of the transplant. So I said, fair enough, I'll buy that.
If it stops some of those dangerous behaviors.
If I stop some of those dangerous behaviors, yeah, I might make it.
Or running in the streets.
Yeah, stay off the motorcycle. So anyway, we need to be honest about that. But so here are some of the unclear things that I found in hospital charts. The disease will take life in the near future. New developments in prognosis. And I've heard that before. You never know what's right around the corner, right? Will likely not recover. Worsening overall prognosis guarded. I expect her to do poorly. So you can see again how these are not helpful comments in terms of helping our families. So in another set of charts, these are, when I say implied state, these imply that dying was likely because of the particular care plan, care philosophy, the care regimen, or the planned pursuit of care, which would suggest by that clinical scenario that this patient is dying. And here are some of the comments that we would say: patient is palliative, patient is comfort measures only, palliative care plan, palliative philosophy of care, comfort measures, no aggressive care, patient may be discharged to the PCU if they make it. And so we can see that the language, when it's non-specific, it doesn't necessarily help anybody. So we want some specificity. I referenced earlier the negativism of our death speak, and this is rooted in a number of different causes. We'll see things like what he's doing poorly, she's failing. And this is all predicated on failure versus a natural outcome. right? And this instinct of doctors, again, trained in a fix-it educational realm, who feel that they have failed if the patient dies. And I've seen that. I remember a conversation I had with an oncologist many years ago. Young woman came in her 40s with widely metastatic stomach cancer. They tried 6 weeks of intervention. She was not a surgical candidate, and the disease continued to progress as expected, And that's an important part of this thing. I was involved, and she died 6 weeks after she came in. And I remember the oncologist repeating back to me, says, "I'm such a bad doctor, such a bad doctor." And I would relate to him. I said, "No," I said, "you're a great physician and a great oncologist. You knew coming in that this was something that you could not fix." "Yeah, but there should have been something. There's got to be something. I'm such a bad doctor." Now, you can imagine that someone who adopts that philosophy, that will motivate how they're going to approach the treatment care plan of a patient. If they think that their singular and sole responsibility is to somehow keep somebody alive, or if they think that they can cure, in fact, when cure is not possible. So this fix-it mentality continues to pervade, and it really is what gives rise to this negativism, death speak. And that also yields this concept of giving up, which is, it's a burr in my side that when people talk about that, the patient's giving up. And again, this withdrawing care, using that terminology, can confer the notion that care will no longer be provided, which is, we understand that's the antithesis of the truth, but we need to be careful about the words we're using because of what implications that can convey. Related to that is how we use this language. Do you want everything done? Sometimes I use the word aggressive care, or do you just want comfort measures? This frosts me too. I believe everybody walking into the door of a healthcare system deserves comfort measures. They deserve the opportunity to have their symptoms managed and to have a comfortable experience. And everything done, well, I want everything done that is relevant to the disease. But the problem is that when you say everything or aggressive care, that suggests that we're giving a menu a la carte of all the interventions available in the hospital system, and we will use them randomly and indiscriminately. How about if we just went to a terminology, well, everything you need and nothing you don't, relative to what the disease is, what your current condition is, and what your values are, what's important to you. That's going to be what drives the plan of care. Not just this blanket statement, you want everything done. Well, who would say no? No, I don't want anything done. Well, that seems a little bit odd too. So we need to get back to this as a false dichotomy that somehow just comfort measures or aggressive care. How about both? I don't often self-promote, but I had an article published just early in the year about the quality versus quantity, and revisiting that dichotomy, because I think it's an important distinction. So we see this also in the hospital charts when they'll say stable. The patient isn't in the ICU, they can't survive, but it's hemodynamically stable. And so the docs will lock onto that. Or again, missing the forest for the trees. The nephrologist sees a patient in the ICU, sepsis, ARDS, requiring 3 pressors, maximal vent support, telling the family that from his perspective, things are better today because urine output has increased. And how often have we seen that where families are getting mixed messages because too many of the practitioners are working in silos, and from their perspective, things are getting better. But in fact, we know that the patient can't survive. A lot of people get pegged in on dialysis without considering the reality they'll never go home. And they may end up in a facility, or they will never leave the hospital because of the nature of their disease. And yet we do these interventions and somehow delude them into thinking that that is better. So we need to be careful about the implications of the plan of care relative to the language we use. So I would argue that we should learn their story and use their story to set the goals. We want to make sure that our healthcare focus is relational and not transactional. The transactional one is just saying, here's, I'm a hammer, there's a nail, everything looks like a nail, right? That old idiom. We want to make sure that the relational aspect of medicine is never forgotten and never lost. That the relationships that we establish with our patients and families allow them to be vulnerable and share with us their hopes, their dreams, their fears, their passions. And if we know what's important to them and we understand the context of the disease process that they have going on, allow that to direct the therapy, then that's going to be a much more effective way of managing something that we can't fix. That's a focus on the big picture, and I think that's critical. And we have to always remember that what we do is not about death and dying, it's about living. So when our patients die, that's what we expect. It's not a surprise. And we shouldn't be setting patients and families up for the expectation otherwise. This is a disease from which people don't survive. And so we expect that that's going to be the case here. So let's talk about what life's going to look like between now and then. It's not a problem to be solved. It certainly is sad and filled with grief, but it's not a crisis and not a cause for panic. It is what we expect to happen. And I think that our medical care system has been so good at crisis management and the ER mentality of rescuing people from these disastrous circumstances. This is not the patient population we're talking about. These are people that have something that we know is going to result in their death. And how do we guide them and help them through that process? So I'm going to argue for the need for honesty, and I don't think that probably anybody on this call would argue that, but I would submit that many of us fall into that trap. I would suggest all of us have from time to time. And one of the biggest ones is that we do is the if rather than when. And it could be something like someone who we're managing for end-stage CHF. Well, if you get to the point where you become short of breath, no. When you get to the point, we understand what happens is COPD, CHF, all these chronic non-malignant diseases. We understand how they progress. Your progressive neurologic diseases, you have some of the ALS. It's not, well, if you should develop difficulty swallowing. No, when you develop difficulty swallowing. I think that addressing them straightforward with real language, with honesty and clarity, we have greater opportunities to help our patients navigate their disease. So think about that the next time you're tempted to use if rather than when. If we know that a certain disease progress is in fact going to move in this direction, then we use the when. And I think that's really important. Also, I think that we need to focus on this misperception of families, of our terminology when we're treating someone. This focus came out of a study that was done several years ago of patients with lung cancer, and this was done on a group of patients with stage 4 lung cancer, who they interviewed after their first visit with the oncologist. And the goal of this was to try to determine whether the patients understood that they had a terminal disease. They were all stage 4, so by definition, they had a disease that could not be cured. About 2/3 of the patients thought they had a curable illness. And the researchers thought that seemed kind of strange. This was a multi-center study. We don't believe necessarily that oncologists are lying to their patients. So what's going on? They replicated the study. Different sites found similar numbers. So they decided they would talk to the oncologist to find out, how are you presenting this? And what they found was this use of the word treatment rather than cure. They were very upfront about saying this is something we can't cure. However, we have treatments for this, and we think that they would be very effective in helping you with your cancer. Patients perceive that language treating this as synonymous with cure. And so they thought they had a curable, even though they were told it was a non-curable illness, by virtue of how it was presented to them, they felt that they had curable illness. So we need to be careful about how we're using these types of words with our patients. The other thing that I think is when we talk about couching reality, the euphemisms that we use for death and dying. And if I asked everybody else, we could come up with probably, everyone would have a little bit different one. We would have dozens of different euphemisms that we use for death and dying, whether it be, passing away. Some people still use expired, as if they're a gallon of milk. And so there's all sorts of different euphemisms that we use to avoid confronting the reality of death and dying. And there's two things that are related to this. One is that there's a societal taboo around the subject, still is. We are a death-denying society, right? And we really don't like acknowledging that. We don't like talking about it. And so we will couch it after they've died. They passed away, right? They died. I just read an essay from a medical student that I was grading. And there were at least 8 or 9 references to death and dying in that, and not once was the word death or dying used. And they used, I think, 4 different euphemisms to try to couch that. So we see that even at this young, formative age. So I think we need to be honest about that. The other thing is, beyond the societal taboo, is that we as physicians continue to have a difficult time acknowledging the reality of death in our patients. We already sort of alluded to our training in a fix-it mentality that fosters that. The problem is that the use of this code language to say someone is dying can make it unclear for the dying people and those close to them to really know what's going on. So if we're not clear about, if we're just, well, they're getting worse, as opposed to know that they are dying. This is what dying looks like. It can make it hard for teams to communicate if they don't understand the implicit code. So again, straightforwardness is really important here. Euphemisms can be used to make a difficult subject easier, and I acknowledge that. As I said, we all slip into that. I have as well. Or obscure the lack of certainty there can be around death. I remember it was a humbling lesson for me. I had come into our inpatient unit, and usually I would kind of gather and chat with the nurses first, grab my rounding list, and then head out to see the patients in the unit. On this particular morning, the staff wasn't immediately available, so I grabbed the rounding sheet, and there's a list we have that would identify those patients who are actively dying. So I saw one on the list, so I thought, well, I'll go in there first. So I went in the room, and it was a very, very sedate, quiet room, and the family was sitting around, kind of thoughtful and stoic. And I looked at the patient, who was motionless, and I saw no movement of the chest, and I thought, got my stethoscope out and put it on the chest. There's no heartbeat. I'm, kind of grabbed for a pulse. Actually felt a little cold. This patient is dead. And I thought, then here's the family sitting there around him. So what do you say in that moment when, it seems the time has elapsed? And I slipped into the comfortable, and and I looked in, I said, I'm sorry, but he's gone. They looked at me, says, yeah, he was pronounced dead a half an hour ago. So, that lack of communication with the staff did impact me at that point in time. But even just, I found myself saying he's gone, like he left or went somewhere, instead of saying, he died. So we all slip into that, but we need to be careful. And I think we want to kind of move to a direction of being more straightforward and diminish the use of the euphemisms. Our terminology versus patient's terminology. I think it's important to listen to what patients are saying And they will give you cues and clues as to what language works for them and what doesn't work for them, and how they perceive different words or terminology. What are they trying to say? We're not called on just to fact check and correct them, but we need to understand the meaning behind the words. Patients will be afraid of the word cancer, but they would, the doctor said there was this growth, or there's a spot on the X-ray, or the type of words that they use. And so we need to listen to them carefully to find out what they mean about that. I remember way back decades ago in my family medicine days, I sat down with a gentleman to tell him that his CT scan demonstrated end-stage pulmonary fibrosis. And at that point in time, that was still is a fatal disease. Transplants were not really available back then, and there were no other really treatment modalities that were effective. And so what I knew is that he was going to have a life expectancy, maybe about a year and a half, is what we sort of estimated. But we didn't get there yet. He was there to talk about the results of his X-ray. And I told him, I said, the X-rays showed a progressive disease called pulmonary fibrosis. And he just breathed this sigh of relief. He says, "Oh, thank God, I thought it was going to be cancer." Well, the reality is that if it had been cancer, he would have had a better prognosis than fibrosis. So what patients interpret into the words that they have heard and they have seen, we need to know their story and how they're interpreting what's being told to them. Likewise, we need to understand what are we trying to say and how can our words best convey that in such a way that they know that we know what they're experiencing. We tend to cloud our language in medicalese. The older we get, and hopefully the deeper relationships with the other patients, we can be more in tune with their language, their conversant capabilities. I think about the experiences I've had with patients that have been both negative and positive for me in terms of my learning curve. But I was asked to see a young man. He was in his 40s with metastatic lung cancer and having significant bone pain as a result of that. And I was told that this gentleman was very resistant. He was oppositional. He had a persona, very, very rough and rugged and a bit vulgar, and was engaging no one, just didn't want to talk, didn't want to hear anything. And so they asked if I would go in and see him and help him with this pain. So I walked in the room and he was lying on his side facing the door. When I walked in, I said, "Hi, Dr. Mulder here to help you with your pain." And he rolled over and faced the wall, didn't want to look at me. And I waited for a moment and I said, I had a chance to look at your chart. And I said, this really sucks. What a shitty thing to happen to somebody. I don't typically use that kind of language when I'm first meeting someone, but after a moment, he rolled back over to face me with tears running down his cheek. And it was the first time that anyone had really talked to him in non-medical terms and acknowledged that this is a shitty thing to happen to him. And that helped to break down a barrier that allowed us to not only get him some help that would make him more comfortable, but to ultimately arrange his hospice care and a meaningful disposition for him. So we need to understand where patients are coming from, the language that they use, what's behind their story, and what is that we're trying to say to them. And often we use this medical language, but it's not what we really mean that we want to say to them. So let's think about that. And we need to perhaps move away from this concept of right and wrong language to helpful and non-helpful words. What would be helpful in this particular circumstance so that they would understand and that will convey what it is we're trying to say. And then what is non-helpful? So other terminology things. This was one that I've seen. I saw this once in in a code conversation the resident had, in which they just simply asked the patient, well, do you want to live or do you want to die? Well, I want to live. Well, then you're full code. Well, we can see, nobody wants to die. And so the issue is never if a patient wants to live or die, but how they will continue to live in spite of having something, whoops, I missed the end of the sentences, something that we can't fix. So we need to be careful about how we're using that language. And again, this concept of giving up, that somehow if we don't embrace an aggressive disease management course that may or may not even work for the patient, that's giving up. And we see that coerced and influenced by healthcare providers and certainly by families. We see that, well, mom, you don't want to give up, do you? We see that all the time. And so we need to help families with their language and how they are, and to diminish that particular verbiage so that it's not giving up. It's acknowledging the reality of the disease, looking at how we want to live and putting a plan in place that will support that. That's not giving up. That's not giving up. That's I think that there's a lot of courage and a lot of forthrightness that goes into making a decision on hitting that disease head on, acknowledging what it does, and choosing to live well in spite of that. This was just a Dalai Lama quote, says, be kind when possible. It's always possible, okay? And just a little bit to be honest whenever possible, it's always possible. And so I would just like you, especially the fellows, to kind of contemplate, have there been times in which you have found that you have maybe skirted being direct with the patient? And if so, is that because of your fear? Or is it because of medical uncertainty? But are there times and circumstances in which we have not been directly honest with our patients? Because I think that we have that obligation to them. So I wanted to close with just, again, my beef with militaristic language, the battle metaphor. As I mentioned at the outset, we see this all the time. We see that on billboards, we see that on ads. And I think it's unfortunate. It is the word of choice in many media stories, in conversation amongst family, friends, coworkers. It's a battle when people face a medical crisis. And we see that all the time. Lost his battle with cancer is something we see in obituaries all the time. How often do you read that? How often do you see that? How often do you hear that? Well, here's one of the challenges. In a battle, there are winners and losers. So tell me, how do you beat dementia? How do you beat ALS? How do you beat terminal cancer? I would remember back when I was working in the ALS clinic, and I would have someone says, I'm gonna fight this disease. And I would look at them very compassionately, say, you're gonna lose. Let's not look at this as a battle, but let's look at this as how you're going to embrace the reality of what's going to happen. Stay a step ahead of it. Continue to live well and live proudly and live with dignity. But don't see it as a fight. It engenders the perspective that somehow the patient is responsible for the outcome. And it's predicated on his will to fight. And, some people survive and they do well. Is it because they fought a good fight? Am I alive as a result of my transplant because how well I fought? No. There was a medical system in place that had a plan. I was fortunate to receive a lung. It grafted well, and it still works pretty darn well. So I'm, it has nothing to do with my fight. Okay. So some people die from their disease. There were people that are getting transplants at the time that I did that are not alive right now. Is that because they didn't fight hard enough? What a terrible thing to put on a patient and a family. Like if only you'd, fought harder, you would have still been alive. And I think that's one of the basic challenges with these battle metaphors, particularly when we're dealing with terminal diseases. But still, people cling to that language. They want to be seen as a fighter to do all they can to beat a disease. And this further instills the ethic that if you don't fight, however you define that, you've given up. we need to make sure that we are not unwittingly foisting this challenge on a patient, that somehow they are responsible for the outcome of their treatments, especially in the midst of a terminal disease. Let's instead encourage patients to think of illness as part of their life experience. This is their story. This is what they have. This is, and it's going to be part of it. And I will often ask when someone uses this language, what does being a fighter mean to them? Does it empower them? Does it encourage them? Or is it exhausting to them? I think that we need to be very honest about that, because it really can be exhausting to I don't know what transpires in the minds of people that wake up in the morning and say, I'm going to fight this disease. I don't know what that means for a lot of people. And we also want to direct the conversation such that patients won't feel like they're set up for failure if the disease progresses. And I'm smiling to myself because I just put the word if in there, and it should be when. Direct the conversation such that patients won't feel like they're set up for failure when the disease progresses. So I slip into this too. You all slip into that. Suggest an alternative an alternative perspective. Use the word advocate instead of fighter. Encourage them to advocate for the most appropriate treatment for them at any point along the way. And that might be choosing a particular intervention, and it might be choosing not to pursue a particular intervention. And assist with values-based goal setting based on reality. Here's the reality of the disease. Tell me what's important to you, and then we will meld those together for a plan of care. That's advocacy. It's not fighting. It's advocacy. Advocate for the life they want to live, given what their disease is. So this is a statistic: 23% of patients with solid organ tumors die in an ICU on a ventilator, often because there was no thoughtful, honest discussion between the doctor and the patient, and often because they were fighters. And this is how the medical care system helps them manage their fight. Okay. I just think it's wrong. So I'd like to consider this. If you live the life you want, that you design, that our patients design, when your values are honored and your goals are based on what is sacred and meaningful to you, when you die, you will have won the battle. In that scenario, you cannot lose any battle to any disease. And you don't need to have someone put that in your obituary, that you lost the battle. You won the battle. This picture is sort of hard to see on the screen. And this is hanging in a museum in Oxford, in the UK. And what was interesting about this is a battle. It's Indian, and it comes from the 16th century. And the slides will be available on the YouTube link if you wanted to explore this in more detail. They don't know who the painter was. But they use this as the metaphor for battle language around terminal disease. And they said much of the language around terminal disease and end-of-life narratives employ the metaphors of the fight: battle, war, victory, defeat, bravery, courage. And the language can represent a very visible and open approach to death, placing the dying person in a publicly combative relationship with their disease and often with reality. I love that statement, and I think that's true. Does it make a difference to the doctor to be cast in the role of a warrior in a battle? And then finally, is this language problematic or a useful set of metaphors to encourage and support the dying and the bereaved? I think it's problematic. I think my interactions with patients over the years would suggest that it's more problematic than helpful. So anyway, that's what I've got. I'll stop the share here and see if there are any questions or comments? There we go. All right, any questions that anybody has that they'd want to share? I see we've got a couple things in the chat box. Can you pull up the chat there? I can't do it.
Just the audio at the beginning, so.
Oh, gotcha. Okay, good to go. All right.
Hi, Dr. Mulder. It's Carol Robinson.
Hi, Carol.
Hi, great presentation. And you had a slide up when you were talking about prognosis and about how it's usually focused on time. And you did mention function. And I just thought that that was worth repeating, just because so often what I've found is, sure, they want to know time, but we really focus on what that time could look like and what they want it to look like to have their best day every day, which I think is one of the strengths of palliative care. So I always tell my, when I'm talking with people, it's, are you asking me about time or are you asking about what that time is going to look like?
I like that, Carol. I'm thinking back to the example that I gave of the lady who was going to do Thanksgiving in May. Part of that was, her initial thing was, is she going to be alive in by November to be able to do that?
Right.
And what I said, you are not going to be better than you are now. You will continue to fail. You will continue to become weaker. And, this disease will make it make you less capable of being able to enjoy the moments together. The sooner you do these things, the better. And I think that's the importance of being honest with prognosis, is that they're only going to get worse as their disease progresses, and the vitality that they have, the functional capacity that they have, will continue to diminish over time. So, so enjoy those now, and if you can enjoy them later, again, great. But so I appreciate that. Thank you, Carol. Jay, you were going to say something.
Yeah. First of all, just again, fantastic. There's so much here. I thought a few things. One, you've been doing this for better part of 40 years, right?
Yeah, pretty much.
And even so the meta message here, to especially to our more junior colleagues and fellows. This is easy to say. It's not necessarily the easiest thing to do. John's been doing this for 40 years, and still in this presentation today, you had the humility to say, "Oops, I put an if rather than a when." Right. So none of this is to say that we expect you to be perfect every time. Because keep in mind, what we think is perfect today, we might, culturally use different words in the future. This is an evolution. One of the things I really would like to stress is the concept of, in shared decision-making, the concept of values-based, what was your word? Values-based goal setting. And again, whose values? Predominantly our patients and then their loved ones, right? How do we work our medical knowledge to then partner up with them in those ways? And another thing, with a lot of times the militaristic euphemisms are very much zero sum, winner or loser, right? Good or bad. And a lot of times what we do is try to frame things in a much more of a non-zero sum. To John's point, and in many of us have seen, we've seen, most of our patients we care for will die. If our only view of success in medicine is who survives, 100% of the time we will eventually fail. But if we reframe that into who is living well, even with these circumstances, and again, that comes back to the values-based. And so there's a lot here. This will take a career to even get to where you feel like you're modestly. And then, I'm glad we value just having this conversation.
Yeah. Just a couple of comments in the chat box there, Mike. I appreciate what you said there. Whoops, I just lost it. I hate this mouse.
You want to read it here?
Yeah. Sometimes you have to walk with people in their desire to fight early on in the journey. But as things change, they're more open to accepting the perspective of winning by living well. I like that one a lot. That's a great comment, Mike. Winning by living well while dying despite the disease. That's a great comment. It often takes a few visits and changes. And I think that reinforces the need for the relationship. Again, we need to be relational as opposed to transactional. C's comment was, I wonder if euthanasia's growing interest is due to the fear of pain and loss of control. Absolutely it is. Absolutely it is. And I think part of it is that struggle that so many people have. And their desire, they realize they're trying to fight and they can't win. And so if they can't win and they're going to lose this fight, then the only option they've got is to get out of life earlier, hasten the disease process or hasten death. Donna, I appreciate, often am told I'm a direct communicator because I'm very honest with people in the manner you suggested. Well done, well done. I also received many opinions about not talking about prognostication. I know we are always learning to communicate honestly and kindly. So that's, we absolutely are. So.
I'd like to just share a couple things, if I may.
Go for it, Kayla.
Yeah, I think one thing, and this kind of goes along the lines of what you've said, is we like to say, I think we read in the chart, the patient failed chemotherapy, 3 lines of chemotherapy. The patient did, they failed this. And that language is important, especially relating back to the fighter language. It's not the patient that failed, the chemotherapy failed the patient.
Exactly.
And so, making sure that we are not like, that's just a way that maybe doesn't directly seem related to that fighter language or the battle language that really is. And I sometimes at the end of life, when the patient is very clearly dying, but family is just struggling to really accept where they are and like lean into just focusing on comfort, I've kind of called that out. And I've said to the family, this is not because of your loved one's lack of trying to beat the cancer. This is because cancer is a bad disease. They have bad cancer and they did everything they could. And just reinforcing like, this is not giving up. This is accepting where we are and just calling out that like, are we giving up if we do comfort or just focus on end of life care?
Well said. Thank you.